quick question. How many people say to people in the community or pregnant ladies that there is another test available other than the current one that's available on the NHS, which obviously is non-invasive prenatal testing? How many people say to patients that there is that test available? 2. You don't surprise me at all. I've lectured in Birmingham, Manchester, and now here, and the number is usually sort of like 2 or 3 out of a room full, so it doesn't surprise me. Just to introduce you, this is My Healthcare. We're a private company based, I'm the managing director of the company, and we opened in Leeds in 2003. 2 main people, well, there's 4 of us really. Professor Howard Cuckold, who is Professor of Epidemiology for Leeds University. So he was a pioneer of the double test, the triple test, the quad test, what we now call the ADMARC test, which then became first trimester screening, sort of like within the NHS. Indira was his sidekick, so she was doing all the data control, etc. And then there was myself and Gerald, both sort of like clinical from Ultrasound. And we realised when we formed Leeds Screening Centre that we needed a biochemical arm and the ultrasound arm to combine together. So we formed what we call now Leeds Screening Centre, which has now become This Is My, because we couldn't open up in other areas of the country we call Leeds Screening Centre, so we just rebranded as This Is My. So that's how we sort of like formed, etc. with it. And we now have a team of over 30 people covering 8 locations. Currently not got one in Scotland, but we have got one in Durham for people who want to just hop on the train and come down to see us in Durham. And so a brief history of where we've come from and where we are now. So in 1991 we had the double test, which then became the triple test in the NHS, looking at placental biochemical markers. In 1991 also there was a paper published on looking at what we call the nuchal translucency, which is a thickening which I'm sure you're all now aware of at the back of baby's neck. And obviously if it's increased in size it will increase your risk. If it's decreased in size then it reduces your risk based on your maternal age and perhaps other factors that you might want to factor in like smoking and other things. And then we had the quad test, so we added in inhibin. These are all second trimesters. And then in 1998, Howard introduced into the private sector something called PRIMARC testing, which looked at 4 biochemical markers and the nuchal translucency. Incidentally, a year before, we actually found, a guy called Dennis Lowe found in maternal blood fetal DNA. It was like, oh my God, why are we doing all this when we've got fetal DNA in maternal blood? Let's just go straight to that. There was a slight problem. We lost it. We couldn't find it anymore. And I'll come on to that because it's a great story and you should look it up because it's brilliant. So we went along the lines of still sort of like doing what we call first trimester screening. So we were offering first trimester screening in 1998. And then in 2003, Howard was being moved on from Leeds University as an innovations company with Leeds Antenatal Screening Service. And we wanted to form a company offering first trimester screening to patients because it wasn't available in the NHS. And obviously everybody wanted a nuchal scan. So it was either a nuchal scan or you could combine it with biochemical markers. Obviously, if you add more markers into the equation, you get better detection rate, lower false positive screening rate. So the more markers you do, the better the test is. So we also had a test called GenMark for those people that had missed out on the first trimester screening test, where we combine what we call the neck thickening in the second trimester, the nuchal fold. It's just to play on how you measure it, and 4 biochemical markers. But we also then started including the nose bone, so again more markers were added into it. And then in 2008, we made a little bit of a breakthrough with next generation sequencing. I can remember Howard coming back from a conference saying, we've done it, we've got it. And Gerald and I said, great, when's it available? We can only process 10 samples for the whole world in a week. Right, okay, come back and tell us when it's available. Then in 2011, so only a few years later, we were able to produce more samples, more cost effectively, and in 2013 we introduced it into the UK, non-invasive prenatal testing. and the test was quite expensive. That was its downside. It was over $1,000 just for the blood sample. So there was, problems with it. But like with all technology, the more samples you can process in a certain amount of time, the technology price comes down. And even up until sort of like last year, we were putting what we call a 14-plex. So we could only process 14 samples on one system. We're now up to 98. So it's going to change, it's going to advance, and it's going to get cheaper and cheaper and cheaper, just as DVD recorders have. Yeah, you can now pick one up in Asda for £10. The original ones were over £1,000. So that's where we've come. Just going back to Dennis Lowe, because it is a lovely story. This was published in The Guardian in September 2003, and it's a lovely article, and it's lovely in the fact that he found this DNA in maternal blood, looked all over, couldn't find it for 8 years. He looked, couldn't find it anywhere. He was about to give up. And then he found an article that was looking at cancer cells, and it was in plasma. And he went and looked at it in the plasma, and there it was all along. And he just says, this was the only thing that we were popping down the drain. We were throwing that bit away, and that's why we couldn't find it, was we were just throwing it down the drain. And it's a lovely, lovely story. He was about to give up, and look at where we are now. So, going back to screening options, in the first trimester, we've now got what we call the combined screening test for those people that have missed out in the NHS for either a failed nuchal or they've just booked too late. Then there is the quad test. Privately, Admark and Genmark still exist, but we do few and far between, quite frankly now, and even Genmark, we don't really do any more of them because the price differential is literally about £100 between doing a combined test looking at placental markers and doing NIPT, so most people will now opt for NIPT. And it is called NIPT or NIPS or whatever you've got to call it. It is a test, and there's plenty of manufacturers out there on the market. Just going back to the biochemistry, this is how we did it in the old days, in the fact that you looked for increases or decreases and you got your calculation. So a 1 was the normal level. And if you can see here, when you look at the NT was raised significantly in most pregnancies that were high risk. And that's how the calculations were all based on. So ideally, we should be a MOM figure of 1, and they not all are 1. So realistically, on the NHS, and I've circled these are the 3 that you put in. So you'll have a low PAPA, high HCG, high nuchal. And when patients come to see me that have had previous screening within the NHS, then the first question you ask them is, did they get the nuchal? Yes. Was it normal? Yes, it was. I'll say we'll have either a low PAPA or a high HCG. How do you know that? Because you've got a risk of 1 in 49, you've got a risk of 1 in 20. So you can tell how your profile is of what risk you're going to get and why you've got it. The Down syndrome screening test, obviously, you've got a false positive screening rate of 2 to 3%, detection rate 75 to 90%, and these two trade off each other. With NIPT, you can do it much earlier. Detection rate is over 99%, 4 Downs, Edwards and Patau's, and that's what the NHS are going to concentrate on. And the false positive screening rate is less than 0.2%. So you're putting less women through invasive testing unnecessarily. There are plenty of companies out there on the market. They're all NIPT tests. So you've got the Harmony test, which is offered through TDL within the UK, NIPT, which is BGI Healthcare, which is we send our samples to Hong Kong. The Serenity test, and I'm speaking on behalf of Cooper Genomics, we do send a lot of samples because it is a good company and it is based within the UK, and people don't sometimes like the DNA sending out of the UK for obvious reasons. Things getting lost, and they're always frightened of what's going to happen with the DNA. They're still paranoid about it, as some people. You've got the Panorama test, and obviously you've got the Iona test as well. They're all, I say, over 99% accurate. So you can choose any one of them off the shelf. It's which supermarket do you shop at? Which car do you buy? They're all products. They're all non-invasive prenatal tests. So how do you choose a test? I will choose any one of these tests. The criteria for my testing is I want a good blood price, I want a low redraw rate, and I want a fast turnaround time. And they're all competing against each other. So I will shop around. Sorry, Cooper. How does ultrasound still play a part? Ultrasound still plays a major part in NIPT in the fact that you've still got to know various things about the baby, and there's so much more you can tell from a pregnancy by still doing the ultrasound scan. Depends what the NHS will want to do with it and how much in depth they will look. And again, it's still a postcode lottery of what people actually look at within the NHS as well. So from an ultrasound point of view, going forward. So first of all, obviously the baby changes over time. So this is a pregnancy which is only 6 weeks, so it's the size of sort of like a grain of rice. But predominantly, this is a stillage, but what you can see is a heart beating away, so you know you've got a viable pregnancy. As it gets bigger, obviously you can see more detail, etc. This is only 10 weeks, but you can already see that nose bone and the maxilla forms very quickly. This is a tiny little, what we call physiological hernia as well. So there's lots of things that we can see. The testing can be done from 10 weeks onwards. Panorama do theirs from 9 weeks onwards. But most of them, all the other companies, are always 10 weeks onwards. We still like, from an ultrasound imaging point of view, like to know that it's viable. We want to know the fetal number, and if there are more than 2, what type of twin is it? We want to know the chronicity. Currently, it's only available, NIPT is only available for twins. We can't do triplets yet, so if we've got triplets, we're back to the old method of screening, and even combined screening is no good for them. So realistically, you're back to your old test of a nuchal translucency. Have you got an increased nuchal? Are you looking at twin-to-twin transfusion? So you're back to the old methods, even in sort of like twins and triplets when you look at them. Because again, if you've got a high-risk result, you want to know which twin it's coming from if it's non-identical. We obviously want to know the gestational age, but also there's lots of anatomy you can check in the first trimester as well. We can check head, heart, arms, stomach, cord insertion, bladder, legs. So we want to know it's got 2 arms and legs. We want to know that it's not, that the stomach's the normal size. We want to know that there's not an exomphalus or a gastroschisis. We want to know that the bladder's there because the kidneys must be working. And also we can look at lots of markers. We can still look at the nuchal translucency, because when we look at the nuchal translucency, if you've got a normal nuchal, you can be reassured to say, well, actually, this is reassuring now. NIPT hopefully will give you a bigger tick in the box, because it's much more accurate than I am at the risk calculation, because it's still a risk calculation, it's still a screening test. We can still look for the presence of the nose bone. So the nose bone being present would, in the old school, would reduce your risk by a further factor of 3, it being present. So if you've got a slightly increased nuchal but a nose bone present, it's probably the nuchal's normal for that pregnancy because the nose bone's present, but you can never vouch for it because there's various combinations, and Downs is difficult. Downs is very subtle. With Edwards and Patows, they tend to have other structural abnormalities wrong with them, and they tend to grow small for dates. Downs is subtle, and it gets subtler as the pregnancy advances as well. We can look at what we call the ductus venosus, which is a little vessel in baby's tummy, and I'll show you some pictures of it. Tricuspid regurgitation and facial angle. Never got to the bottom of facial angle, I have to say. And a new marker called the intracranial translucency as well. So let me show you some pictures of these. So nuchal translucency, this is a normal one. This is an abnormal. You can see it's thickened here. Nose bone, I'm going to quickly go through this. This is the nose bone here. Now you've got an equal sign and then a tip. This is the nasal tip. This is the skin surface. This here is the nose bone. The white line underneath the first white line. You can see here that it's absent. And that is what everybody says, oh, that's a nose bone. It's not, it's the one underneath that is actually the nose bone. And you've got to hit it at the right angle. If you get it all right, you should be able to see the nuchal and the nose bone on the same image. So that's good. We can also move on to the ductus. This has got reverse flow in the ductus. Now the ductus is a tiny little vessel that basically shunts the blood through the liver. Instead of it going through the liver, it shunts it straight through the liver from the portal vein, because mum's feeding baby all the nutrients there, the oxygen in mum's blood, there's the food in mum's blood, so it doesn't have to go through the liver, because your liver is your combustion engine. So when you eat something at lunchtime, your portal vein flow will significantly increase to get all that energy through the liver, to combust it to make energy, to then go to the heart, to then go to the lungs to pick up your oxygen, to then go off to your body so you can run around the rest of the time and concentrate on all these other lectures. In baby, it doesn't have to do that. It shunts straight through the liver, into the IVC, back to the heart. So there's a close connection with the ductus and the heart. And if the heart is abnormal, you'll get an abnormal blood flow in the ductus venosus. That's the theory on it. And you will find as well that with these waveforms, you get a different waveform for an Edwards, a Patau's and a Downs baby. So you can tell potentially what you're looking at on scans sometimes. It's really, really useful. And also, if you've got an increased nuchal and an abnormal ductus and it comes back normal for a chromosome abnormality, then you're going to go look at cardiac defects. So it's a good indicator. Tricuspid valve, again, because it's in the heart, you're going to get abnormal blood flow patterns. And the facial angle, I've really never got to the bottom of it. Apparently, it's a flat. You get a flatter face with a potential baby with Downs. And I can remember Gerald coming back saying, "Oh, facial angle's a new one. I bought you a present." And he walked in with a protractor. I said, "I haven't seen one of these since I was 12 at school, and it's sat in a drawer and never been touched, and it's still gathered dust because we never used it. We never got to the bottom of it, I'm afraid." And for the risk of spina bifida, this is the little thing that we're looking for here, another little white line. And this is the intracranial translucency. And potentially with spina bifida, you get tethering of the spinal cord. Because you've got tethering, it pulls this white line out of this area and you just get a black space. So that's the theory behind spina bifida. With the nuchal translucency. Spina bifida is actually on the decrease because our diets are getting better and we are getting folic acid in our diets, but you still will get some that that come up with spina bifida still. So that's what we look for there. So how does non-invasive prenatal testing fit into that? Well, once we know all those things are normal on scan, then all we need to do, and it's so simple, it is just like doing what you normally do now with the biochemical markers. You take a blood test from mum's arm, but you put it in a special, what we call Streck tube. These Streck tubes are still quite expensive, and this then gets sent off to the lab, and we sequence it. And it basically counts the chromosomes. If you've got too many chromosomes left over, why? Because we should all have a same normal pattern. So we'll count, some companies will just count 13, 18, 21. Some will test the whole genome sequencing, and things are changing on that. But from an NHS point of view, it's going to be 21, 18 and 13. So what we do is, once we've got the blood sample from mum, we fill in a consent form which asks for various details about gestational age, a bit like filling in your first trimester screening form, very little difference, just give them the data, send it off to the lab, and we get a result back depending on the company between 3 and 10 working days on receipt in the lab. And these timings are coming down, and come December the 1st, we're going to launch what we call an express service, which will be 3 days. These are the results. So when we get a result back from the lab and they've counted the chromosomes, we get a result for 13, 18 and 21. And there are various companies that do it various ways. Now, Cooper Genomics is quite, basically says they've not detected anything or they have seen something. With the triple test and obviously the quad test and the combined screening test, you're given a risk 1 in whatever. So 1 in 10 to 1 in 50,000 or 100,000, etc. With the NIPT tests, it differs slightly in the fact that you're either one extreme or the other. So when we get results back from other labs and they've not detected anything, we'll sit down and say, how many digits are we counting there? Is telephone digit length? If they have detected something, it's 1 in 20, 1 in 10, 1 in 5. There's no middle ground with NIPT. You're a one extreme or the other. And so this company here has just said, we've not detected anything, or we have detected anything. There is a suspect range with this where sometimes they'll request another blood sample. It's usually for 18 or 13 that is suspect. But we'll usually do a redraw first, have another look at baby and redraw it, because we are reliant on the amount of DNA that circulates in mum's blood, and all our placentas work differently. So that's sometimes when you're asked for a redraw. And when you've detected something, we get an aneuploidy detected. So who comes to us for NIPT screening? At the moment, it's a real mixed bag. 25% of our population have had a previous screening with the NHS and they've come back high risk. Advanced maternal age, people just knowing that there's a better test out there and they want the best test available, so maternal anxiety. I got told off once for, we always, obviously maternal age is over 35, and I think this lady was 41. It's just, how can you put advanced maternal age? Oh, just tick maternal anxiety then. So you've still got to be careful, but there is a box for advanced maternal age, maternal anxiety. Previous affected pregnancy, they want to know, and they want to know, tend to be as soon as, they tend to come to us at 11 weeks because they're desperate to want to know that everything's right with this pregnancy. They've had trauma last time around. Failed NT. We get lots of people with failed NT, and when people ring in saying that, you know, they failed the NT and they just want a scan to make sure everything's normal, I try and give them reassurance, because I say to them, if you've had a failed NT, it's usually because it's normal. Big NTs hit you in the face when you're scanning them. Difficult to get NTs are usually small. It's reassuring that they didn't get the NT, but usually we'll get the NT. We've never failed to get an NT, so it's reassuring that when they come to us that we can say that. And somebody who just wants simply the best test. So between up until June, we've done 5,500 tests. Still the maternal age is sort of like more advanced, but you know, we get a whole age range now, and that's significantly changing now. And we'll get people coming anywhere from 10 to 38 weeks. I know we've had people that have said, I just want to know before I give birth. Fine. There's little we can do about it. They just want to be prepared. So we get a whole spectrum, but usually it's in the first trimester or just after. 65% centre samples are less than 14 weeks. And realistically, originally 90% of clients wanted to know gender, and I think there's a move away from wanting to know gender now. I think it's a more of 50-50 split, because people know that they can get gender and now moving away to actually wanting to keep it secret. And it's a bit like everything comes in and out of phase at the moment. So gender is changing, and lots of people do want to keep it a secret, which I think is lovely. But yeah, the test can actually screen for the gender. It looks for the presence of the Y chromosome. Interestingly, it's still only 98% accurate for the gender. And this, again, it makes me giggle, this story, and I'm glad there's more females in the room than males, sorry. But I was speaking to the guys in the lab, I said, how come you get the gender wrong? You say it's female and it's male. And Tassos from Greek said, because the Y chromosome is small. I said, you know what, that explains so much more than a failed than failed gender wrong. So yeah, so the Y chromosome is small, and that's why they get it wrong in that direction. But most companies will offer a resample for testing again as the fetal fraction increases, because it does increase with maternal age. And it is a test that you should be talking about, because on your NHS Choices site, it does say that it is a better test, and therefore there's no reason why you can't say that it's not available on the NHS. We are trying to get it. It is still a relatively new technology, but if you want to go out and find it, not just our company, there are other companies out there being able to offer it as well. So just tell them to go look at a website. They'll find a centre that offers NIPT without a doubt if they want a better test. And I want to say thank you to Cooper Genomics for allowing me to speak on this subject again. Thank you.